to the Academics and Clinical Education series. The theme today is Hypogonadotropic Hypogonadism boys. I'll request all the audience to put their questions in Q&A section. I would now invite Dr. Anurag Pachi, our president, ISPAE. Sir, sir, please unmute.
Thanks, Jalak, for inviting and conducting this wonderful program. ACES is one of the prime academic programs as part of ISPAE, with the main aim of spreading awareness about different disorders on pediatric endocrinology. This we conduct every 3 months, and we try to correlate the entirety of that topic using two very interesting case scenarios, which are then discussed in detail, followed by two expert sessions in that regards. The Indian Society for Pediatric and Adolescent Endocrinology is aiming to enhance the quality of care of children with pediatric endocrine disorders. And one of the prime ways of doing that is to empower the clinicians in the management. The topic for today is very interesting, and we have been really lucky to have two renowned speakers from across the globe who will be covering this wonderful topic of hypogonadotropic hypogonadism in boys, right from diagnosis to the management, including management till the fertility section. So it's a real going to be a very interesting session. We are joined by Dr. Margaret Zacharine from Royal Children's Hospital, Melbourne, and Dr. Nalini Shah. I'll hand over to Dr. Vijay Kumar, who will be moderating the first case, to please take over and carry from the case discussion part. Over to you, Dr. Vijay. Dr. Vijay is a very senior pediatric endocrinologist, a professor and head in Department of Pediatrics at Government Medical College, Kozhikode, Kerala, and he has been working a lot towards enhancing awareness and access to pediatric endocrine conditions in Kerala in general and across the country overall. Over to you, Dr. Vijay.
Thank you, Dr. Anurag. And first of all, I express my sincere gratitude for the team behind this program, the ISPAE ACES team, for giving me a chance for at least for mentoring this program. So we have two eminent personalities here, and the topic hypogonadism in boys is a very fascinating topic nowadays, because gone are the days we just treat the child with testosterone and just see what secondary sexual characters appear or not. So without wasting much time, I'll just ask the first presenter, Dr. Urvi Swaika. She is a fellow in pediatric and adolescent endocrinology, Manipal Hospital, Bangalore. She will present a topic of a boy with hypogonadotropic hypogonadism. And we can start, Urvi, and your time is 20 minutes. So try to finish it in 20 minutes. Thank you. We can start.
Yes. Thank you, sir. Good evening, everyone. I'm Dr. Urvi. I'm a fellow in endocrinology in Manipal Hospital. I'll be sharing my slides. Yes. I'll be presenting a case today of a 16-year-old boy who had come to us with a complaint of small phallic length, undescended right testis, and no pubic or axillary hair noted. There was a significant past history of orchidopexy for right undescended testis at 1 year of age. Birth and developmental history was uneventful, normal. The father, in family history, the father had started shaving at 16 years of age, and the maternal menarche was at 14 years of age. There was no history of any delayed puberty or any late height spurt in the family, no late bloomers. There was no history of any systemic chronic disease, that is any weight loss, respiratory infections, blood transfusions, tumor, short stature, neurological disorders. There was no history of any anosmia or hyposmia, and no history of any radiation, chemotherapy, trauma, tall stature, gynecomastia, or mumps in the child. On examination, the child had central obesity. Systemic examination was normal. There was no dysmorphism or synkinesia, that is mirror movements. The SMR, the Tanner staging sexual maturity rating was prepubertal. No axillary hair, no pubic hair. Testicular volume, right side was not palpable. Left was 1 ml. SPL was 4.5 centimeter, which was micropenis at his age, 16 years, it should be 13.3 plus minus 1.6 centimeter, and it was also buried, but the stretch penile length was still 4.5 centimeter. Anthropometrically, the child's height was on the 50th centile within the mid-parental height range. The weight was above the 75th centile. The child was obese. the BMI was in the obesity range. And on examination, as I said, the child had central obesity. The stretched penile length was 4.5 centimeter. Right side testis was not descended. Left side was 1 ml, and there was no axillary or pubic hair. Sorry. So the child had come to us around 1st of May this year, 2025. The baseline investigations, hemoglobin was 12.3, ESR was normal, creatinine was 0.5, thyroid was normal with a TSH of 1.7. The child was overweight, so to rule out any fatty liver, dyslipidemia, diabetes, the HbA1c, OTPT, triglycerides, total cholesterol, lipid profile was done, which were all within normal limits. For the puberty investigations, LH was less than 0.1, FSH was 0.129, total testosterone was 5.89 nanogram per dl, less than 20, which should have been more than 20 at his age. Free testosterone levels was 0.013 nanogram per dl, which should have been 2.93 to 19.5 nanogram per dl at his age. Bone age was 12.1 years, AMH was 5.87, and inhibin B was 2.55 picogram per ml, which should have been more than 35. One second, sorry. Yeah, so on the basis of the examination history and the investigations, it appeared to be a case of hypogonadotropic hypogonadism. There was no history of any late bloomers, delayed puberty, height spurt in the family. The bone age was not delayed more. Sorry, this was a mistake. The LH FSH levels were low. LH was less than 0.3. FSH was less than 1. Testosterone levels were low, and inhibin B and AMH levels were lower than that is expected in CDGP. So the provisional diagnosis was of a hypogonadotropic hypogonadism. The karyotype that was sent was of a normal 46XY, and the genetic report came later after we had started the treatment. It came on this follow-up, which showed the child to be a FGFR1 mutation, heterozygous, which is a cause of isolated hypogonadotropic hypogonadism, IHH. The child did not have any anosmia. There was no, it's not Coleman syndrome. Autosomal dominant inheritance, pathogenic variation classification. So the child was started on HCG injections, 1000 IU twice weekly. For 1 month, child has received this. Plan is to increase the HCG dose and then later start testosterone with FSH, and plan for repeat orchidopexy if there is no increase in the or descent of the right testis. On follow-up after 1 month, when the child had come to us, the SMR was A1. Pubic hair has started to come. The right testis is still undescended, with the left has increased to 2 ml with a SPL of 4.5 centimeter. This was my case. I'll be talking about delayed puberty and hypo, the approach and the treatment in brief. So delayed puberty in boys is defined as the lack of testicular enlargement volume is not more than 4 ml when checked by the orchidometer by 14 years of age, or a gap of 4 years between the start of testicular enlargement and the completion of puberty. So here we can see that in the basic anatomy, if we see the hypothalamus producing the GnRH, the pituitary producing the LHFSH, and the gonads. So in this case, there are basically, depending on where the lesion is, whether it's in the brain, the hypothalamus or pituitary, or whether it's in the gonads. So delayed puberty can be classified broadly into hypogonadotropic hypogonadism and hypergonadotropic hypogonadism. So in this case, there's a primary failure. The gonads are affected, which is causing an increase of the positive feedback of the GnRH and LHFSH, which will cause high LHFSH with low sex steroids, that is the testosterone levels. That is primary failure or hypergonadotropic hypogonadism. Whereas in this case, whereas in this case, there is a defect at the hypothalamus or a pituitary level, causing decreased GnRH, LHFSH levels, which will eventually cause a decrease in the sex steroids, testosterone levels. So we'll get a low values for all LH, FSH, and testosterone. This is secondary failure or hypogonadotropic hypogonadism. Hypogonadotropic hypogonadism, and eugonadotropic hypogonadism, which is rarely found in males, more common in females. So in this, as we said, there will be low FSH-LH sex steroids, which can be either constitutional delay CDGP or hypogonadotropic hypogonadism, which can be pathological or functional hypogonadotropic hypogonadism. Hypergonadotropic hypogonadism will have high FSH-LH, low sex steroids, which is most commonly primary gonadal failure. Common could be Klinefelter, or chromosome analysis should be done. And eugonadotropic hypogonadism, in which the LH-FSH levels are normal with low testosterone levels. These are the common causes of since the topic is hypogonadotropic hypogonadism, I'll be discussing further only about hypogonadotropic hypogonadism. So the common causes are firstly CNS tumors, infiltrative diseases, example astrocytoma, germinoma, glioma, craniopharyngioma, prolactinoma, Langerhans cell histiocytosis, Rathke's pouch cyst, genetic defects, Coleman syndrome. A number of genes are involved in this. ANOS1, COL1, which codes for the anosmin protein, FGFR1, which was involved in our child, but there was no anosmia, hence we do not call it Coleman syndrome. PROC2, PROC-R2, these two are involved, are associated with obesity. FGF8, these FGF8 and FGFR1 can also be associated with midline defects like cleft palate. HS6ST1 and CHD7. Isolated hypogonadotropic hypogonadism, again FGFR1 is one of the genes implicated in it. Other than that are GNRHR, GNRH1, FGF8, PROC2, HPG, hypothalamus pituitary gonadal axis development, NROB1 or DAX1, NR5A1, HEXX1, LHX3, and PROP1. Obesity and hypogonadotropic hypogonadism, Prader-Willi, Bardet-Biedl, and Charge. These are few of the syndromes that can be found. Gaucher's disease, inborn error of metabolism, prior CNS infections, midline defects like septo-optic dysplasia, congenital hypopituitarism, chemotherapy or radiation, or trauma. So idiopathic hypogonadotropic hypogonadism and Coleman syndromes are isolated defects in the pituitary GnRH secretion. IHH can either be sporadic, which is 66%, or familial, 33%. Inheritance can be X-linked, autosomal dominant, and or autosomal recessive. COL1, which encodes anosmin-1, a neural adhesion protein present during organogenesis. This is necessary for the normal embryonic migration and appropriate neural spatial relationships. Associated defects in the if there is a mutation, the defects can include visual defects, nystagmus, ataxia, synkinesia, midfacial defects, and renal agenesis. FGFR1, which is the protein is encoded by COL2 gene, mutation is associated with deficiency of the fibroblast growth factor signaling during the olfactory bulb morphogenesis and an autosomal dominant form of Coleman syndrome. It can also disrupt the hypothalamic pituitary gonadal axis, leading to cryptorchidism and hypogonadotropic hypogonadism. Basic approach, if a child comes with delayed puberty, so the first line evaluation should be firstly a proper history taking, especially to ask for any family history of any delayed puberty, any personal history, example, any history of mumps, any trauma, any surgery, any chronic illness. Auxology, that is the growth rate, velocity, and the sexual maturity rating is very important. Then third, we go on to the investigations. First line investigations are the basal LH, FSH, IGF-1, prolactin, testosterone, thyroid, and the bone age. So if we get, as we discussed, if we get a low LH, FSH with a normal growth rate velocity, second will be a low LH, FSH with a low growth rate velocity, and third will be a high LH, FSH. So if we get a low LH, FSH with a normal growth rate velocity, we will suspect either hypogonadotropic hypogonadism or a CDGP. If we get a low LH-FSH with a low growth rate velocity, it could be a sign of functional hypogonadotropic hypogonadism. And if we get high LH-FSH, then that is a hypergonadotropic hypogonadism. So the second line evaluation after we get a working diagnosis is in hypo or CDGP. We go in for a GnRH stim test if indicated, inhibin B levels, olfactory test, MRI brain, and if required, a genetic test, specially indicated if there's a strong family history. Functional hypo, check the BMI. If the BMI is high, it could be a case of steroid-induced delayed puberty. If it is low, it could be a case of anorexia and some eating disorder, or like, for example, in athletes. And if it is normal BMI, it could be a case of growth hormone deficiency. In that case, growth hormone stimulation testing is considered. In hypo, karyotype and inhibin BR, karyotype is most important to rule out Klinefelter syndrome. So the AMH levels have been recently. It's AMH levels and inhibin B have been started being used as useful biomarkers for the prediction and differentiation between CDGP and hypo. So this was a recent article published in January 2025 in the Endocrine Journal, which showed that an AMH level above 20 combined with the inhibin B level exceeding 28.5, that had a high diagnostic specificity of 83% to distinguish CDGP from CHH. For example, in our patient, AMH was 5.9 and inhibin B levels were 2.5. So both were lower than these ranges, indicating more towards CHH rather than CDGP. This is just a normal physiology of the AMH levels. So for example, it is high in the initial period and in the mini puberty and the childhood stage. Later, it starts decreasing towards puberty and adulthood. In CDGP and CHH, AMH can be normal or slightly elevated or abnormally low, indicating delayed or impaired pubertal progression. AMH is also a predictor of successful sperm retrieval. So lower AMH levels less than 2.6 can correlate with a higher successful sperm retrieval. So once we have established that the LH-FSH and testosterone levels are low, we need to differentiate between CDGP and idiopathic hypogonadotropic hypogonadism if we haven't been able to. So CDGP will commonly have a short stature, normal phenotype, final height and the SMR will be normal, and there might be a family history present since mostly it is autosomal dominant inheritance. Whereas in IHH, there might be normal or tall stature, sexual immaturity will be there in the phenotype, there will be an abnormal phenotype, and family history may or may not be present. On investigations basis, testosterone in CDGP and IHH, CDGP, the testosterone could be more than 20. That will predict a testis of more than 4 ml by 12 months and 15 months. Basal LH will normally be more than 0.6, whereas in IHH it will be less than 0.3. Basal inhibin B will be more than 35 in CDGP and less than 35 in IHH in boys. AMH levels should be less than 20 in IHH, and bone age there will be a delay of more than 2 years in CDGP. It will be almost normal in IHH. Even if there is still confusion after the baseline test, we can go in for the GnRH agonist stimulation test using leuprolide or triptorelin. In that, the stimulated LH, if it is more than 5.3, it is suggestive of CDGP. If it is less, it is suggestive of IHH. And the stimulated inhibin B more than 111, again suggestive of CDGP. Because inhibin B is produced from the Sertoli cells, so that means that there is a sufficient FSH action happening on the Sertoli cells causing the release of the inhibin B. This was the approach and the evaluation. Now we come to the treatment. So this was the treatment that was initially earlier followed, where only testosterone was given. So in hypogonadism, it was started at around 50 mg every 4 weeks. Then every increments were done of 50 mg every time, every 6 to 12 months. After reaching 100 to 150 mg monthly, then the interval was decreased from 4 weekly to 2 weekly. Adult dose was 100 to 200 mg every 2 weekly. The different testosterone preparations can be used. Enanthate is the monthly one, and undecanoate, the Cernos that we get, that can be given 3 monthly, 1000 mg every 10 to 14 weeks. There are gels and other patches which are available that can be started when 50% of the adult dose with IM testosterone has been achieved. But with this, it was noted that only external virilization was happening, but the testis growth and spermatogenesis was not happening. So then the use of HCG and FSH started. So there are different protocols being followed in different countries. So in NHS, they had taken out a guidelines saying differentiating it between testicular volume less than 6 ml and testicular volume more than 6 ml. So basically their premise for this guidelines was that if it is more than 6 ml testicular volume, it means that there has been sufficient Sertoli cell proliferation during the mini puberty stage. So you don't need to start with FSH. So in more than 6 ml, they started with HCG and then they increased to FSH if required. Whereas if the testicular volume is less than 6, so they start with FSH to stimulate the Sertoli cell proliferation, and then they added HCG later. So in between the testosterone levels, I think ma'am will be speaking about that. They measured the FSH levels, testosterone levels, and monitored for any side effects of HCG. For example, gynecomastia, acne. If anything like that is not there, then it is increased, and then semen analysis is done within 3 years once the testicular volume is more than 10 to 12 ml. So the Margaret ma'am's article was there from Australia, in where they had studied and they had come up with the guidelines to start with HCG 500 IU twice per week and then increase it gradually while monitoring the testosterone levels. So around after 6 to 12 months, after 6 months, it should be around 10, and after 12 months, it should be around 20 nanomole per liter. And it is continued till there is sufficient sperm production for storage. I shall not be going into the detail here. This was also Margaret Ma'am's article, in which they had compared two groups. Group A was prepubertal HH boys with absent or early arrested puberty. So they were started at a low dose of HCG, 250 to 500 IU twice per week, and gradually increased. And then later FSH was added. Whereas Group B were HH adolescents who had previously received the full testosterone replacement. So they were started at a higher adult HCG dose, that is 1500 IU twice weekly. And similarly, testosterone levels were monitored and later FSH was added. A recent article that had come out from PGI Chandigarh, in that they had said, since HCG is known to sometimes have deleterious effects later on, so they tried, there are three therapies. They said we can either do HCG alone or give piggyback or sequential therapy, or else you can have a triple therapy LFT regimen, in which they tried to study whether low dose HCG was as efficacious as high dose HCG. So their conclusions were that it is non-inferior to the conventional high dose HCG therapy, and they had also studied the AMH and inhibin B level, that it has good potential for proxy of spermatogenesis. Cryptorchidism and micropenis in infancy. So male patients with CHH can have micropenis and cryptorchidism due to a gonadotropin deficiency during fetal development and the postnatal period of mini-puberty. Other associated clinical signs known as red flags include synkinesis, mirror movements, deafness, midline defects, cleft palate, renal agenesis, skeletal teeth, and ear anomalies. So the mini-puberty, that graph I had shown before, it provides a window of opportunity for diagnosis via the endocrine investigations. Inhibin B and AMH, as I said, are useful markers of Sertoli cell function in males even after mini-puberty. And inhibin B, if it's CHH patient, it will be characteristically quite low. Inhibin B and AMH can also be seen low with anorchia, but in anorchia, normally they'll have high FSH-LH, raised gonadotropin levels, so that can be distinguished from CHH. Cryptorchidism can by itself also lead to delayed puberty, depending on whether it is syndromic or acquired. So the treatment for micropenis and cryptorchidism in the neonatal period is, for micropenis, we give either IM testosterone enanthate 25 mg instead of 50 mg, which was used for pubertal induction, 25 mg every 3 to 4 weeks for 3 months, or topical therapy with either 5% testosterone cream or DHT cream. Whereas management of cryptorchidism is surgical correction with or without the use of HCG or GnRH therapy adjuncts. Studies are still going on to see how much of an effect how useful they actually are in the further surgery. Few studies showed improved testicular size and function, but also HCG high dose has been shown to have deleterious effects on germ cells in cryptorchid in testis in infants. They might result in smaller testis volumes and higher FSH levels in adulthood. Thank you.
Thank you, Dr. Urvi. It was a nice presentation. Actually, you have concluded within that stipulated time also. And I think we can hear the discussion by Margaret Madam and Nalinisha Madam about the recent trends in the management of hypogonadotropic hypogonadism. There are no questions in the chat box.
So there is one in Q&A, sir.
Q&A, I think I'll see. Was leuprolide stimulation test done in this child?
No,
I think Urvi can answer.
Yes, sir. No, so it was not done because the baseline investigations, the bone age, the history and the examination, they were all suggestive of CHH, and it was not possible to do the leuprolide stimulation test, so it was not done.
Yeah. So if there are no further questions, I think we can straight away go to the talk. So I invite Dr. Nalinisha Madam. Nalinisha Ma'am doesn't require any introduction, and she is the doyen of pediatric endocrinology in India. Presently, Madam is Emeritus Professor, Department of Endocrinology, KEM Hospital, and Sage GS Medical College, Mumbai.
Thank you. I think I truly need to be grateful for this opportunity to interact with the audience of pediatric with interest in pediatric endocrinology. And I think because of the background from which we come as a Department of Endocrinology, where we kind of look after both the children and the adults, all the right and the wrong which is done in pediatric group related management is what is evident to us as these children start growing, and then we are able to sort of see what possibly could have and should have been done for these children. And that has been a biggest learning curve for which I'm extremely grateful to my institution and my brilliant postgraduates who always generated such huge level of interactions. So Urvi, thank you very much for setting the stage for the whole background that you prepared along with the case. So I'll try not repeat what you have already said in your presentation and then the discussion that followed. What I have tried to do is that I've tried to kind of just take up a lot of gray areas which are involved in both the clinical assessment of these individuals and especially as it relates to the outcome of various test parameters which are done. So what I'd like to point out through this discussion is that things are never so black and white, and there's a big zone of gray which lies somewhere in between, which we are responsible to kind of figure out exactly what it all adds up to. So this is a classic presentation of a 14-year-old boy who comes to get for attention for the first time with poor secondary sexual characteristics. And then the question comes up is that what is the best way to approach these children? Should we be, sorry, I'm just going to take out the cursor. So basically, I think the whole question is the clinical assessment alone enough? And do we really then need to supplement it with the relevant biochemistry? Because typically, when we work with all resource limited settings, I think you learn to value each of the investigation and the incremental information that it generates rather than just a blanket kind of a menu option of looking at multiple test options. Is genetic really needed for all children who present with delayed puberty? Because though it's available, it's not at all uncommon for it to generate a lot of background noise and concern with the parents and the patient equally to find out if there are certain findings which may not be of any relevance whatsoever to the child. And of course, the management, which becomes so hugely important and pertinent, which is what Dr. Margaret would be looking into. So we are aware of this physiology, and I'll just like to sort of use it as my prop to understand the pathological outcomes in which different clinical scenarios emerge, that during the first 15 weeks of gestation, it is only the maternal HCG which is driving the Leydig cells to produce the testosterone and hence the development of external and internal genitalia. The Sertoli cells by themselves are responsible, as we know, for AMH, and here lies the complete development of external and internal genitalia. It's only after 15 weeks of gestation that the GnRH neurons have migrated, and now the HPG axis has taken over, resulting into the further growth of external genitalia and mini-puberty, which is the last part of the third trimester and the early part of the infancy, which culminates into further testicular growth, further penile growth as well, what we call as a mini puberty, and the most important aspect of which is FSH-driven Sertoli cell growth with enlargement of the testes, which are going to nurture the germ cells, bringing in that required volume to be accrued at the time of puberty, so that puberty starts at a much better baseline. During puberty, we do realize this entire axis which kicks in right from kisspeptin to hypothalamus to the anterior pituitary and the relevant cells in the gonad, which are responsible for its individual hormone-based manifestations. So, of course, the delayed puberty, when we talk about it, kind of has an age group to say not having started puberty, but also it encompasses the definition to say the puberty which is not progressing normally. So you may have a start of puberty, but the progression of puberty is rather stuttering, or it is very, very stretched and inappropriate for the age of the child, which also is something worthy of assessment and perhaps further management. So we have this kind of a nomogram, which we can refer to at the different age groups to tell us what would be the -2 SDs of testicular volume at different age groups, which could be of value addition in understanding the delayed puberty and its actual assessment. So also, one must relate to single fact in life that we don't want to ever wait till 14 years of age. If there are sort of signs and symptoms which are present much before that, we use them as our flags, and we kind of try and understand what is the concern which is afflicting a given patient and the family members. And we need not wait for the magic figure of 14 years. Even in the fetus or in the newborn baby, presence of micropenis and cryptorchidism is extremely significant, and that would tell us that there is a problem with HPG axis and its functioning, and is absolutely meritorious of being investigated, assessed, and even managed in that particular time. What we also need to remember is that there are a huge gray or partial development of puberty, where typically the magic number of more than 4 ml of testes is present, but there is no growth of that testes which is being documented, and that becomes equally important as a segment or as a group of patients which need addressing. Completely well-developed secondary sexual characteristics as well as growth, which is in keeping with pubertal stage, may be present, and yet it could be one of the manifestations of hypogonadism being reflected only with low sperm count, and that is also something that needs to be borne in mind. Somewhere in between is our constitutional delay of growth and puberty, and that forms the major chunk of all the children that we encounter as in the clinical practice, and an extremely important domain which needs to be understood and investigated appropriately. All partial or incomplete puberty or even absent puberty can show complete reversal and march towards completion of puberty. They're also known to reverse back into state of hypogonadism. So that is also a spectrum that we need to be aware of. And an adult who's completely well-developed, even fertile, can have an adult onset of hypogonadotropic hypogonadism is another end of the spectrum that we need to be aware of as well. So these are the commonest 4 scenarios that we encounter, the most important of which, before you proceed with any aspect of pubertal assessment and which ought to be ascertained, is a state of functional hypogonadotropic hypogonadism. Then the commonest variety, which is constitutional delay, and what then follows is hypogonadism, which could be hypo or a hypergonadotropic hypogonadism. And as this particular bar suggests, what we ought to remember as a clinician, the largest chunk of patients that we encounter are self-limited, physiological delayed onset of puberty, which are very hard group to differentiate from early age of hypogonadotropic hypogonadism. And the even core set of investigations, which would be very nicely highlighted, may not be able to differentiate between the two. So let's always respect the fact that investigations are very important, but they may not hold all the answers. So functional state of hypogonadotropic hypogonadism is best differentiated by understanding the history and having basic set of investigations, just like a blood count and bicarbonate, creatinine, IgA, TTG, or TSH. And these, along with a clinical history and assessment, should always allow a pointer towards figuring out if there was a systemic cause which was leading to hypogonadotropism. Between the self-limited delayed puberty and a state of permanent hypogonadotropic hypogonadism, there are set which we must use towards its differentiation from the hypergonadotropic hypogonadism. Remember that the child first comes to us as a patient, and it's only after that we are going to ask for the relevant set of investigations. So an arm span which is more than the height is a very common denominator which you see in hypogonadotropism, whereas the arm span and the height related difference is lost in Klinefelter syndrome because of the long leggedness. Gynecomastia, to an extent, is very useful. Severe degree or moderately severe degree of gynecomastia is more representative of hypergonadotropic hypogonadism, though you will see mild gynecomastia even in hypogonadotropic hypogonadism, and we should remember that. And of course, our FSH and LH are going to be very, very useful in differentiating between the two entities extremely clearly. Now, we know that this is the axis, and we understand the fact that any state of permanent hypogonadotropism could be the originating from either genetic problems which are related to GnRH neuronal migration, development, or functional state being impaired, or an acquired cause like pituitary tumors. And all of these can be fairly well understood if we pay attention to the clinical signs and then ask for a relevant biochemical investigations. The clinical signs which are of great importance is understanding the state of whether or not the child has anosmia or normosmia. It ought to be understood that if there is a historical formation of anosmia, you need not do UPSIT test for figuring out presence of absence of sense of smell or otherwise. A state of hyposmia, it will give you incorrect answer even after the test, and it may or may not be possible to differentiate even on the test parameters. Always look out for the clinical symptoms or signs which allow you to pick up these kind of anomalies, and they are a very good pointer towards underlying genetic causes. Never miss the syndromic component like heterochromia, a flock of white hair, fundal changes, or in a patient who's got dentin-related abnormalities like hypodontia with neurological deficits. Any associated components of syndrome or other systemic involvement is always a pointer towards underlying genetic cause, and we should be conscious about it. Never miss out on a family history. It's amazing that even when the family members are present in extended family, patients and the family do not appreciate it and they do not come forward with that particular history. So proactively asking for these history in a relevant manner in keeping with the mode of inheritance is definitely important. Our own work, which kind of lasted for more than, I think, more than a decade, and when we sort of looked after close to 200 patients with the genetics of hypogonadotropic hypogonadism through various publications, what we have learned is that in India, unlike the world literature, normosmic variant of hypogonadotropic hypogonadism is more common, and that perhaps is because of consanguineous marriages which are more prevalent in our state or in our part of the world. Never miss out the fact that hypogonadotropic hypogonadism could be because of the underlying neurological concerns and neurological issues, like in this patient with craniopharyngioma, this patient who had a giant prolactinoma, and very understandably, the complete focus of management and associated pituitary deficits are going to be the fulcrum around which the management is going to be based. So be careful about understanding, evaluating the clinical spectrum carefully as to not miss the acquired causes from the genetic causes. We may be forgiven for missing out the underlying genetic cause, but obviously the acquired cause is going to be extremely important because a complete change in the route of management, which is going to happen in these patients. We have several test parameters which are available depending upon the domain that you're trying to investigate. Are we trying to investigate the central control of the gonad, or are we really trying to investigate the gonadal functions in terms of the differential functions of the Sertoli cells and the Leydig cells? Or are we combining all of them and asking for the relevant tests? Is what we need to understand from a clinical picture and then ask for the relevant tests. Let's understand the performance of each of these test parameters. Irrespective of which test proficiency a particular center holds or the logistics permit you, never overlook the clinical symptoms and signs. Height, standard deviation scores, and the testicular volume as two differentials between constitutional delay and idiopathic hypogonadotropism are of a great value, where constitutional delay children are going to be much shorter and the testicular volumes are going to be much better in them compared to the hypogonadotropism. And please let us not overlook that, because the test parameters do have significant component of grays which are inbuilt. There are several tests and the several papers which have alluded to the performance of various test parameters. Here is a paper coming from Mehul Dattani and his group, which talks about 3 different test parameters and their performances. HCG with serum testosterone done on day 3, done on day 19, and GnRH stimulated LH value to differentiate between patients of hypogonadotropic hypogonadism and constitutional delay. And ultimately what they point out is the combination of the test and all the tests, when they combined together, it yielded a much larger value, which each of the tests buffering out the individual test zones sensitivity and specificity, or the false positivity and the false negativity, respectively. Inhibin and its performance is something which is studied hugely in the recent times, right from basal value to post-testosterone primed inhibin B to FSH stimulated inhibin B, with the various cutoffs which are available, and the data point towards various aspects of false negativity and false positivity, which we need to be aware about. Yes, it's a good test, but let me also sort of give you certain examples of challenges which are encountered despite using these test parameters. There are also extraordinarily involved protocols which are available from the Seminara and her group coming about 5 years ago, where they've studied GnRH primed kisspeptin stimulated delta LH response after LHRH stim test in these individuals. And what they have shown is that patients who progressed through puberty versus patients who did not progress through puberty had extraordinarily well demarcated zones and values. And for obvious reasons, for the logistics and the availability part of it, these test parameters may not be possible to be implemented in our setups. So let's start with some of the clinical cases and see the performance of these test parameters. 14.5-year-old, look at the FSH value and look at the LH value. And I would specifically like to point out this. The FSH, which is looking extremely good, 2 point something, in a child whose testicular volume was rather prepubertal with less than 4 ml of testes, our magic number to say that the puberty has started or otherwise. The inhibin B was pretty good. we decided to just wait it out. And of course, it did show progression of puberty over a period of time, telling us that it was all about a constitutional delay and nothing really needed to be done for that particular child. But look at these two brothers, born of consanguineous marriages. And what we have done in both of them is that we have done their HCG stim test, we've done their LHRH stim test, and both of them performed well on both the test parameters. Look at the cutoffs, which I have depicted by the side, and you can see that both of them have done well with those respective cutoffs. But what did they really have? They actually had hypogonadotropic hypogonadism with micropenis, with KIS1R mutation, which was responsible for hypogonadotropism. And that tells you that you may not have a bankable results from any of these test parameters, and you will have to kind of follow up these individuals, because obviously at 3 years and at 5 years of age, we may not be able to further challenge through the test parameters or through our management principle. Again, another child who presents to us somewhere over here, but actually the history started with bilateral cryptorchidism and micropenis. That is a rather significant history. And though these test parameters were sort of very, very difficult to read and they were abysmal at 1.5 years of age, this child, before presentation to our department, was already treated with testosterone for micropenis. And that's another area of debate, which I'm sure Dr. Margaret Zacharin would be addressing, whether testosterone itself should be used in the suspected cases of hypogonadotropism. And what we saw was that when he came to us, the HCG stimulation test did rather well in this particular child. He was followed up, and at 12.5 years of age, we did not have any sign of puberty which was seen. Also, what we realized in this child is that MRI showed hypoplastic olfactory bulbs. There was a very clear history of anosmia. The mother would complain that this child could really not smell anything. And what we realized is that A, the basal inhibin, and B, the FSH-stimulated inhibin rather met with the cutoff, and so did the basal AMH. Also, the GnRH stimulation test met with the cutoff. The genetics was not helpful in this particular child, but this child, though he kind of showed responsiveness to every single test, had hypogonadotropic hypogonadism and required support with gonadotropin-based induction of puberty. And what we have to learn and understand and respect the fact is that all the test parameters, whichever test that you use, whether you use HCG stimulation test or a GnRH stimulation test or inhibin, all the test parameters and their performance are completely governed by the baseline testicular volume. The more stark is the testicular volume between completely undeveloped puberty to normal patients, the differences in this test will be easily visible. The minute you start introducing the group of partial puberty, like you would do over here, where the testicular volume is more than 6 ml, the differences between the test becomes extremely blurred, and the performance of these tests becomes rather challenging, and you may not be able to derive your answers. Ladies and gentlemen, I'd like to conclude by telling us that let us not overlook our clinical features, which will help us in our differential diagnosis. All the test parameters must be read in the context of the clinical presentation. Partial forms of hypogonadotropic hypogonadism will continue to pose challenge despite all the test parameters that we may use for them in terms of the differential diagnosis. Thank you very much.
Thank you, Madam, for that excellent, lucid, and very informative presentation. So, and you have your time. There is no lag of time, and we have got at least 10 minutes for our answering to our questions in the chat box. So shall I just read the questions? So first question, puberty important in.
I'm sorry, I'm not able to hear Dr. Vijay.
How mini puberty is important for girls? That is the first question.
Sorry, mini puberty
is important for girls.
So mini puberty and its sort of possible importance in girl child is not something which is really well understood as of now. The most characterized feature that we understand about mini puberty, its role towards boys in terms of accruing the right cell mass for the Sertoli cells and hence the number of germ cells. So I must say that for the girl child, we are still not in understanding of how to interpret, and even for that matter, I would kind of raise this question further to say that any aspect of pubertal challenges during infancy or in a prepubertal state in a girl child is a matter of great difficulty in addressing or even investigating.
Yes, that is the answer. Madam, there is a second question. Can you hear me, madam?
Yes, I can hear you.
Is there any timeline between HCG and repeat orchidopexy?
So let me sort of reboot this concept. The whole treatment of cryptorchidism with HCG was being done for so-called the zone of idiopathic cryptorchidism, many of which belong to the category of perhaps gonadal impairment or some spectrum of gonadal dysgenesis which leads to cryptorchidism. Patients with hypogonadotropic hypogonadism and cryptorchidism, perhaps HCG alone may be questionable in its role for management, whether it should be HMG alone or HMG in combination with HCG, which brings you to the management of mini puberty with its role of last phase of descent of testes, which is inguinoscrotal phase of descent, is what I'd rather leave for Margaret, because I'm sure it'll come there in management of mini puberty.
And my third question is very, very interesting. So if an infant is diagnosed with hypo, do we treat during mini puberty too, or at a later?
So I would kind of think that the whole understanding is evolving to relate to few principles which have been learned. In management of hypogonadotropic hypogonadism, one of the larger goal of which is getting fertility. That is clearly related to the testicular volume at which the management of these children begins. And the testicular volume is directly related to presence or absence of mini puberty. Mini puberty and its absence is definitely going to take out that particular phase of testicular growth and hence leave the testes poorer at the onset of puberty with the volume which is definitely on the smaller side. And those are the very patients who do poorly in terms of their outcome for sperm count and fertility. So mini puberty is emerging as one of the zone which should be recognized through its red flags, confirmed and appropriately addressed for management with gonadotropin-based regimes is what we have learned and what we have started practicing, is what I would like to say.
This next question that is in the QA box, that's almost similar question. How to approach a prepubertal boy with isolated micropenis? Should we wait till the time of puberty?
So basically, again, I think I would try to look at it this way, that isolated micropenis in presence of testicular volume, which is normal, we are making sure that this isolated micropenis is part of hypogonadotropism and not just part of, something like a growth hormone deficiency. And I presume when you're asking this question, you're ascertaining that the growth of this child is normal and it's only isolated micropenis that we are referring to. It is not very easy in presence of just isolated micropenis without any syndromic component attached to it, like which foretells the possibility of underlying genetic mutation or a family history which is positive, which again helps you towards making a diagnosis of possible hypogonadotropism, or a genetic mutation which has been found to be positive, all of which give you the strength to make the diagnosis of hypogonadotropic hypogonadism, which is the reason of micropenis. Those are the patients I would, if diagnosed, I would treat them. And I would treat them not just with testosterone. It's quite likely that we could help them with a short course of gonadotropin as possible mimic of mini-puberty even beyond infancy, which is a typical stage of mini-puberty, so as to bring them to the right stage of platform towards future management.
Thank you, madam. One more question. Followed.
I'm sorry, I lost you.
Could be followed.
The question is about in prepubertal boy with micropenis and cryptorchidism.
Yeah,
what should be done first?
What should be the
or GnRH? Yeah.
What should be done for?
HCG stimulation versus GnRH stimulation.
Yeah.
I think if you are trying to suggest or select vis-a-vis the performance to tell us whether it is GnRH stimulation test or HCG stimulation test, I would sort of err more towards the GnRH stimulation test, because I'm trying to now look at it from the point of view of not the testicular pre-primeness. I'm trying to look at it from a defect which is arising higher than the gonadal level, from hypothalamic pituitary level, to tell me if there is a possibility of central control which is impaired, leading to micropenis and bilateral cryptorchidism in these group of children. Having said that, if the test performance tells me that this is coming through as a normal test, a partial form will not be possible to be differentiated from a sort of, it's only the severe forms which the test performance tends to be good.
Thank you, man. No more questions now. I think it is exactly 7:58. We are 2 minutes ahead of the time. Thank you so much, madam. And I think I will hand over the session to Dr. Anurag for the next set of talks. Thank you, Dr. Anurag.
Thanks a lot, Dr. Nalini, for an exhilarating talk covering entirety of approach. And I'm sure a lot of doubts have been clarified, because this is one area which has really changed over the last couple of decades. Thanks a lot, Dr. Vijay and Dr. Urvi, for the wonderful case discussion. And now we'll move forward. We talked about diagnosis, and we're able to achieve what is the cause and whether it's CDGP versus HH. Now, the next question which comes into our mind is how do we manage them? Right from mini puberty to early puberty to fertility and other issues. And for that, I have the pleasure to invite Dr. Kavita Bhatt, who is a leading pediatric endocrinologist from Bangalore, and she needs no introduction. She is working as a pediatric endocrinology at Aster Hospital, Bangalore, working as a fellowship coordinator, and has been involved in a lot of work in terms of pediatric endocrinology research. And so we will hand over to her with regards to the further session, which is more about the management aspect. Over to you, Dr. Kavita.
Thanks, Dr. Anurag. Without wasting much time, I invite Alapan Mahapatra. He's a pediatric endocrinology fellow at Regency CEDER, Kanpur, for presenting his case. Over to you, Alapan.
Thank you, ma'am. Good evening, everyone. Should I go with the slide presentation?
Yes, yes. Go ahead.
Are my slides visible, ma'am?
Yes. Yes.
So I'll start with a case of a hypogonadotropic hypogonadism. I am Dr. Alapan from Regency CDER, doing doctoral fellowship there under guidance of Dr. Anurag Bajpayee sir. Today my case is guided by Dr. Kavita Bhatt ma'am from Astor Hospital, Bangalore. I'll start with my case, which is a case of hypogonadotropic hypogonadism, which we started with induction and gradually moved up to the conception part. So this is a 17-year-old boy presented with lack of development of any secondary sexual characteristics, with bilateral enlargement of the both breast, which was noticed since last 4 years. And there was also no changes in voice for the last 4 years. Moving on to the history of present illness, the patient complains of lack of development of any sexual characteristics in terms of beard or mustache, and there is also sparse development of pubic hair. The mother had noticed the child is still gaining height and there is no change of voice, even though he is 17 years old. There is also presence of bilateral enlargement of the both breast. Initially it was tender and gradually the tenderness goes off, and it was for last 4 years. So there was no history of any anosmia, hyposmia, or family history of anosmia, any history of any synkinesia or mirror lab movement present in this child, no history of any seizure, skeletal changes or hearing defect, no history of any delayed onset of saving in father or menarche in mother as we see in cases of CDGP. There is no history of any headache, visual disturbances, diplopia, any history of any trauma, tumor, infection or radiation to the head. There is no history that the child has given that whether he had initially pubertal onset followed by no progression. There is no history of any increased pigmentation or salt craving present in this child. Also in the past illness, there was no similar illness present in the maternal side of the patient. No hospital admission was there due to any systemic illnesses or any history of malignancy related treatment was present. No history of any repeated blood transfusion present in this patient. The child didn't give any past history or he couldn't remember any history of mumps in the childhood followed by fever, vesicular rash with chill and rigor. And there was no history suggestive of any testicular pain previously with trauma or swelling to the testis. Moving on to the family history, there was no similar history as I have already mentioned about the delayed puberty from the maternal side. No family history of any delayed puberty in parents, and there was no history of consanguinity in between parents. Antenatal history was uneventful. The child was a term child was 3.1 kg with no history of any poly or oligohydramnios, no history of any breech delivery or forceps application or any kind of seizure, hypoglycemia, midline defect or cardiac defect suggesting of multiple pituitary hormone deficiencies. There was no history of any intensive care admission also. The personal history of child was normal and he didn't take any medicine for the last since his birth. Moving on to the nutritional history. The child's nutritional intake was adequate. No history suggestive of any eating disorder. The socioeconomic status was lower socioeconomic status in this child. So based on our history, we can move on to our differential diagnoses, like 4 differential diagnoses right now. They are hypogonadotropic hypogonadism or hypergonadotropic hypogonadism, whether it is a multiple pituitary hormone deficiency or it is a self-limited delayed puberty. So if we combine 4 and we have the pointers like delayed puberty, gynecomastia, short stature and pubic hair, the patient presented obviously with delayed puberty, that is seen all the cases of CDGP, hyper-hypo or multiple pituitary hormone deficiencies. Gynecomastia is usually present in cases of hypo and it is more significant in cases of hypergonadotropic hypogonadism. Short stature is usually present in cases of MPHD or CDGP. And pubic hair is absent in cases of CDGP and variable in cases of multiple pituitary hormone deficiencies, though hypogonadotropic hypogonadism and hypergonadotropic can present with pubic hair. So moving on to the general examination of this patient, the child is alert, conscious and cooperative, faces is normal and vitals were stable, no elevated BP present in this child. There was no pallor, cyanosis, clubbing, edema or jaundice present. Moving on to the SMR staging or sexual maturity rating staging, the child's testicular volume was 2 to 3 ml, which was less than 2 standard deviation score with pubic hair stage 3, and SPL length was 5 centimeter, which was also below the -2 standard deviation score. Anthropometry part, the child was tall with a height of 184 centimeter and weight of 97 kg. So the child was a obese child with a BMI SDS of 1.7 SDS, and his arm span was 181 centimeter. Moving on to the head to toe examination, there was no finger abnormalities present. Gynecomastia was bilateral. It was 5 centimeter, non-tender and firm and symmetrical in both sides. And there was also no secondary sexual characteristics present apart from the pubic hair that is present. So this is the growth chart of this child. Moving on to the systemic examination, the systemic examination was normal in this child. With CNS examination we did for the smell, sensation and other, and it was completely normal in this child. Moving on to the investigation part, the routine investigation for ruling out the systemic causes of hypogonadotropic hypogonadism, but all the investigations were normal. Then we moved on to the hormonal workup, and the hormonal workup has shown that there was low testosterone level according to his age. With this low testosterone level, the LH level and the FSH level, the gonadotropin levels are undetectable, especially the LH level. We moved on to the basal inhibin B, and it was also on the lower side, 30 picogram per ml. So considering the fact of hypogonadotropic hypogonadism versus MPHD, we did other anterior pituitary hormone workup, and cortisol and prolactin and thyroid, as I already mentioned, was normal. We did a MRI brain in this child, and the MRI brain was completely normal. So if we go with the pointers in this child, the age of the child was 17 years, which was quite unlikely in cases of constitutional delay in growth and puberty. The height was on the taller side, which is ruling out almost the CDGP and multiple pituitary hormone deficiencies. Testicular volume is 2 to 3 ml, and there is presence of pubic hair, which rules out the CDGP and other steroidogenic defects. Gynecomastia is present, which points out towards the hypogonadotropic hypogonadism or the hypergonadotropic hypogonadism. Micropenis is there, so CDGP it is less likely to have micropenis. And based on the gonadotropin level, MRI brain and inhibin level, we have the provisional diagnosis: the 17-year-old male with delayed puberty and lack of sexual characteristics, tall height, gynecomastia, and low gonadotropin levels with low testosterone is probably due to a case of isolated hypogonadotropic hypogonadism without anosmia. So we moved on to the treatment, and we know that there are two parts of this treatment. One is the pubertal induction versus the fertility issues. For pubertal induction, some prefers testosterone versus HMG and ACG both, or there are fertility issues which can be addressed later on with gonadotropin injections. For the pubertal induction, we started with a testosterone 100 milligram intramuscular monthly. So after following this 3 to 6 months, the child started developing facial and axillary hair, though there was no increase of the testicular volume. We increased the dose to 50 milligram in every 6 months. And after 2 years, when he has reached the adult dose, we have changed his testosterone to testosterone undeconate with 1000 milligram every 3 months. Following after a few days back, the child again, now he is 28 years old, married for 1 year, and he had approached our clinic for consideration of fertility issues. So we did the initial sperm analysis, and we found that there was azoospermia initially in his sperm analysis. So we considered stopping the testosterone treatment and moved on to the gonadotropin treatment with HCG 2000 milligram and HMG 150 milligram bi-weekly. 2 months later, we increased the dose of HCG as the testosterone level was still on the lower side. Following which, after 6 months, we found on the sperm analysis that there was immature spermatozoa present, and after 9 months, that count increased to 2 million following with the injections of the gonadotropins. The testicular volume also increases to around 10 to 12 ml, and the patient actually conceived naturally after 12 months of treatment. So he opted for further sperm freezing for the further fertility aspects. So the theoretical part has been already discussed in, so I'll just point out suspect in cases of hypogonadotropic hypogonadism in patients with the delayed puberty, small testicular volume with normal onset puberty. The baseline and stimulated inhibin B may be helpful to differentiate between these two, though as ma'am has already described, these tests are not that reliable, and fertility can be successfully achieved with the gonadotropin therapy in individuals with the hypogonadotropic hypogonadism. Thank you.
Thanks, Dr. Alapan. I now invite any questions from the audience. Let me see. So this, in prepubertal boys with micropenicillin, okay, that's over. Is MRI brain a must? Well, I think this is all the previous questions.
No, MRI brain was added now, ma'am.
Okay, so is Dr. Alapan, you want to answer this question?
So in this, when we have moved with a guidelines that if the testosterone level is very low, like less than 150 nanogram per DL, especially the child presented around 17 or 18 years of age, if there is multiple pituitary hormone deficiency, persistent hyperprolactinemia, and other neurological signs, we can then go for, based on the testosterone level that is so low, we consider to go for a MRI brain in this patient.
And then any more questions? In the first case, was the unilateral undescended testis investigated or treated?
Dr. Urvi, I think, yes.
Yes, ma'am, it was not investigated. Orchidopexy was done. It was treated, but despite that also, when he came to us, he still had undescended testis, right side.
Okay. This is Dr. Raghupati's question. Okay. So
One more question, ma'am.
Yeah, one more question. Some adolescents have 20 to 25 ml testis, but not much facial hair. What should be done? Well, I guess it's a genetic condition, and if the hypothalamus, I mean, maybe I should answer, if the hypothalamus pituitary gonadal axis is intact, I don't think there is anything much in terms of endocrine treatment. But I would like to invite answers from anyone else.
Our experts are Dr. Margaret, Dr. Nalini.
Yeah. Dr. Raghupati is also here.
Yeah, sure. So Dr. Raghupati would like to take it, or?
No, Nalini, you can go ahead. I mean,
Sure.
if you have an
So
answer.
basically, I think this is a very common question in terms of poor facial hair growth. And these are sort of individual traits, especially as you pointed out, in a patient who's otherwise HPG axis, which is functionally very normal. Some of these are even fertile individuals who have proven their sort of testicular functions are more than normal, and yet the facial hair growth tends to be sort of on the poorer side, and there is really nothing that we can do about it.
Thanks, Nalini. Could I now invite Dr. Margaret?
Yeah, ma'am had a question,
Yeah.
I think, Margaret ma'am. She had put it in the chat box.
Oh, sorry. Oh, really? I'm not able to see that question. Could you?
Okay. Yeah.
Yeah. Maybe you can
unmute and ask him. Dr. Margaret, you can unmute and ask him.
Sorry, can you hear me?
Yeah, yes.
You can. I was interested in the last case where the boy had been on, or the young man had been on testosterone treatment for a very long time. And yet, with induction of fertility using gonadotropins, there was a very rapid response to the point of sufficient spermatogenesis to achieve fertility. And that would be quite unusual. What are your thoughts about that?
Is this question for Alapan?
Yeah, if possible.
Yeah. Alapan, do you want to try to answer?
Ma'am, actually, we treated the patient around 17 or 18 years age, and then patient was in our follow-up for 4 to 5 years. Then he was lost to follow-up. Then again, he come back at 28 years age when his testicular volume was also similar in the 3 ml or something like that, but the SPL was increased. Later, we started on treatment and the treatment response was good. So we didn't expect anything, but from that, the good response, we taken positive in that sense.
Margaret, so we have a number of cases who did not receive any gonadotropin as part of their mini puberty or during puberty, they treated with testosterone. And when we later on started on gonadotropin, on an average, we have been seeing that from around 6 to 12 months, they'll start showing some spermatogenesis, and we have got reasonable number of cases who have become fertile between 12 to 18 months. So I would say many of the congenital cases may be difficult and they take much longer, but there seems to be certain subgroup which will respond reasonably well to therapy. So he's one of those ones, I would say. Yeah.
I have a couple of interesting comments about that I'll put in my presentation.
Dr. Margaret, there's one question in the Q&A. For mini puberty treatment in CHH infant, how late can it be initiated? FSH 150 unit for three times per week for 4 months prior to HCG. I mean, for how late can it be initiated was the question.
Well, we will usually, if we identify these patients at all, they're usually identified because they have a clear clinical abnormality. Usually the obvious one is a true micropenis, with or without undescended or partially descended testes. Sometimes it will be later. Normal mini puberty starts, as you know, 4 to 6 weeks after birth and continues for 4 to 6 months in males. So any time up to 4 to 6 months should be not unreasonable to try and reproduce the situation. We don't reproduce it perfectly, but we can do our best. If we give FSH, I would normally try to use something like 20 to 30 units of FSH 3 times per week for around 3 to 4 weeks. You should see, if the testes are descended, you should see an enlargement of the testes. And this is really important for seeing that you have effective management. And then you can add HCG, and the dose of HCG should probably be around 30 to 40 units of HCG twice per week. But you can get massive levels of testosterone up to 60 to 70 nanomole per liter, which is huge and really is probably unsafe for future testicular function. So you have to be extremely careful. You have to watch clinically to see that the penis is enlarging at a normal rate and not too fast. And you have to do a testosterone level. For those patients, I would do a testosterone level probably every 1 to 2 weeks while using HCG to make sure that you don't go overboard. And you probably don't need to treat for more than 4 to 8 weeks for most patients. In my fairly limited experience, that the patients who have more complex disorders, particularly the one that seems to arise most often because it is commonest, is charge syndrome, they don't do as well. But there is a big variation in the protocols that are being used, and nobody has a right answer.
Thank you, Dr. Margaret. There's another question by Dr. Raghupati. Since we do not always get any information about mini puberty, should we have any form of screening for mini puberty during infancy?
If there is some suggestion that the child's testes are not well descended or that there's a micropenis, usually those patients, unfortunately not always, but we need to educate those that deliver children. We need to educate the general paediatrician that may be in attendance. We need to educate the nursing staff who deliver so many babies, that if they see either or both of undescended testes or a micropenis, this needs investigation straight away. And so if you can then do an FSH, LH and testosterone during the time at which you might expect mini puberty, that is any time from about 4 weeks onwards to about 4 months of postpartum period, we should see a normal mini puberty. And if we don't see that, that would act as a flag. But the primary thing is to educate our fellows so that particularly the obstetricians, well, maybe the obstetricians don't even look at the babies, but certainly those that are delivering the children, and hopefully if there's an attending paediatrician. Those are the people that need to flag that there's a problem.
Thank you. There's another question. For hypogonadotropic hypogonadism in females, we have one patient, 15-year-old with hypo, short stature, systemic disorders, MPHD ruled out, no CNS pathology. Is genetic study a must, especially if the patient is financially very poor?
Yeah, I don't know that it's going to answer your questions. If you have excluded obvious things like chronic diseases, particularly even in India, surreptitious eating disorders, so over-exercising, this is an enormous problem for us, absolutely immense. You're looking at 1 in 10 girls in Western society now during their teenage years who appear to have hypogonadotropic hypogonadism, and it's due to subclinical eating disorder that is simply not coming to attention. So there are many other things that may not be HH. But what I think is really fascinating, as Dr. Shah was pointing out, nobody knows the value of mini puberty in girls. Does it actually change the immature oocyte? Do we actually have any evidence for fertility induction in adult women with hypothalamic hypogonadism, whether it's better if one had treated mini puberty with some estrogen? I have absolutely no, so it was not some estrogen, with some gonadotropins. Would that have helped mature the oocyte? Would that give them better fertility outcomes in future? I have absolutely no idea, and I'd be interested in if anybody else had a view. But I don't think, to answer your question, that it is mandatory to have any genetic answers, because I don't think it's going to help your clinical management. Other people might have different views, and it'd be nice to have a discussion.
Yeah. Thank you, Dr. Margaret. Any other questions anybody would like to ask before I think that's it. That was a wonderful talk, Dr. Margaret, and thank you once again. Anurag, do you want to take over? Thanks.
Yeah, thanks a lot, Dr. Kavita, for this wonderful interaction. Thanks a lot to Margaret for shedding a light on such an important topic and how things have progressed from the last so many years about this field. And I'm sure the area to watch would be to pick up children in mini puberty, which is one of the biggest challenges. But in terms of practice change, probably is the pubertal induction. Once you're really inducing puberty, then most of us will know. And then differentiating CDGP versus HH and thinking of gonadotropins at that time is what the big message is coming out from this discussion in that perspective. Once again, thanks for the entire team, ACES, particularly Dr. Jhalak, for taking such an effort in making this possible. Thanks, Dr. Margaret, Dr. Nalini. Thanks, Dr. Kavita and Dr. Vijay for being the moderator. Dr. Alappan and Dr. Urvi for the wonderful presentation. And I'm sure this would have helped in terms of practical issues in terms of hypogonadotropic hypogonadism. We will have the next session in September to cover another very interesting topic. So I think we'll close on that. I'll ask Dr. Zalak to have the vote of thanks. Thank you.
Thank you, Anurag sir, for coming up with wonderful ideas for the theme for every ISPAE ACES meeting and our wonderful experts. We thank, on behalf of ISPAE ACES team, we thank our experts for today's meeting. Professor Margaret Zacharin, it was an honor to have you. Thank you for the excellent presentation and thank you for solving our doubts on how to treat hypogonadotropic hypogonadism in males. We also thank Professor Nalini Shah for enlightening us on the diagnostic approach, how to diagnose hypogonadotropic hypogonadism versus CDGP. It was a privilege to have you, ma'am. We thank our moderators, Dr. Vijay Kumar sir and Dr. Kavita ma'am. You led the discussion very well. Thank you so much. We also thank Dr. Urvi and Dr. Alappan for the wonderful case presentation and congratulations, you did very well. We thank all the delegates for joining us today in large number. We thank RX event team for managing it very smoothly. The next ISPAE ACES will be on 27th September. See you all. Before we leave, can you all switch on the video? We'll take a picture. Dr. Alappan? Yes. That's smile. Thank you so much. Thank you, everyone. Good night.
Thank you. Good night.
Thank you.
Thank you. Good night.